Yes,
Yes,
sir.
sir. Please.
Thank you very much for this kind introduction, and I'm really some echo is there. Excuse me.
If somebody is nearby with the two Zoom meetings on, if the mobile is on, please keep it separate. In nearby devices, it happens, sir.
Yeah. Anyway, so I'm really grateful to Department of Oral and Maxillofacial Surgery of Mercy Medical and Dental College for giving me this opportunity to share my experiences on management of space infection, and especially to my friend Dr. Anil. And he has been after me for this lecture, and I was not able to fulfill my commitment the last Sunday also, and even yesterday also.
संकल्प सर आपके दो है, उसमें ऑडियो थोड़ा डिस्टर्ब आ रहा है टू डिवाइस से.
Just 1 minute.
Yes, sir.
Is it okay now?
Yes, sir. Clear, sir.
Yes, sir.
Okay. So we'll start with our presentation. The space infections are for oral and maxillofacial surgeons, they are very common. For general practitioners, they may be a challenge to manage a space infection case. Still, it is equal. Just give me a minute. I'll check my site.
Yes.
I'll try again. No, it is not working. Shall I disconnect and join again?
Yes, sir. Please. Yes, sir.
Am I audible now?
Yes, sir. Clear, sir, it is.
Yeah. So we begin with our presentation on space infection. So as we were discussing that it is very common and probably uh, in a oral and maxillofacial surgery setup but for general practitioners, general dentists, it may be sometimes challenging. So we most of the time people are confused with what spaces these are, or actually is there any space in which the infection collects or the pus collects. So we know that these are not actual spaces present there around the bone, between the bone in which the tooth lies, in which the offending tooth lies, from where the infection is coming, and up to the skin. As such, there is no empty spaces. There are muscles, there are soft tissues, and then skin is there. And in these soft tissues, this infection or this edema spreads and gradually converts into the abscess formation. So I will begin my presentation with the anatomy, with with a few slides of the anatomy of these species, so that you can have a mental picture that what exactly is there in these species. These pictures I have taken during a neck dissection. So you can see that when we give an incision in our skin, just beneath the skin as such, there is no empty spaces. There is a fatty tissue layer is there, which we call as a subcutaneous tissue, or you can call it as a superficial fascia also. And then again, when we go beneath the superficial fascia, this is the space one, we call it. When we go beneath the superficial fascia, again, there is a muscle will come, which is known as platysma. Everybody knows that this is skin, then this is superficial fascia, and then you can see there is a layer of platysma muscle is there. And again, beneath the platysma muscle, where space 2, supposedly space 2 lies, you will see that there is actually, when we cut the platysma, there is actually no space. Again, there is some sort of loose connective tissue is there. And beneath that loose connective tissue, you can see a deep layer of fibrous, a deep superficial layer of deep cervical fascia is there, a fibrous layer is there. We call it as investing layer of the deep fascia. And this forms the roof of the submandibular and the submental space. So this is where we reach after cutting the platysma. So again, you can see that as such, there is no empty space. These are the spaces which are filled with the loose connective tissue or the fascia or the muscle. And now when we cut this investing layer of fascia, we will enter anteriorly into the submental space. You can see this is lined by bilaterally by anterior valley of digastric, and its roof is formed by the myloid muscle. And now you can see that the floor formed by the fascia and the
खुली जगह नहीं
loose connective tissue.
टिश्यू रहता है.
Then when we go posteriorly, again you can see that we will go into the submandibular space. So when we remove the fascia and the loose connective tissue over the digastric, both the valley of the digastric, now you enter into the submandibular space, which is lined anteriorly and posteriorly by the anterior and posterior valley of the digastric, and superiorly by the lower border of the mandible. Medially, again, myloid muscle is there anteriorly, and posteriorly, hyoglossus muscle is there. So again, you can see, and in this picture, we have removed the submandibular gland, facial artery, and facial vein, which otherwise you would have seen in this space. So again, this is not an empty space. Only thing is these spaces are filled with the loose connective tissue, which is gradually displaced and by the edematous fluid, and gradually the pus forms. So this is submandibular space, and this is taken from the below. Inferior shot is taken. Now you can see that the digastric is retracted, anterior valley of digastric is retracted, and the hyoglossus and the lateral pharyngeal wall is also retracted. And this is the medial border of the medial side of the mandible. And now you can see that this is the lateral pharyngeal space. So this is the medial portion of the mandible. This is the medial muscles which has been retracted medially, and this between the mandible and the muscles, these are the lateral pharyngeal space. So actually, when any infection arises, and it suppose if it gets a path out of the mandible, and if it is successfully enter into one of these spaces, it can spread into any of these spaces, because these spaces are interconnected, whether it is maxillary or mandibular. So submandibular and sublingual spaces can be connected to lateral pharyngeal, then retropharyngeal, parapharyngeal. So these all spaces are interconnected. When we talk about space infections, usually they are polymicrobial infections. There can be aerobic infections, anaerobic infections. We know that mostly it is streptococcus, and along with some bacterioids, anaerobic infections are there. So in the initial stage of infection, when there is a cell lattice stage is there, it is mostly aerobic infection, and gradually when the anaerobic environment prevails, the it is anaerobic bacteria are there. So when develop from the same type of carious loop, there are infectious infection.
Sankalp sir. Sankalp sir.
It was disconnected, sorry.
Yeah, sir. It disconnected. Yes, sir. Sir, please share.
Yeah. Is it visible now?
Yes, sir. It's visible.
So certain patient develop only minor dental abscess, but in certain patient you may see osteomyelitis or facial space infection. So this difference depends on the virulence of the bacteria, number of microorganisms, then what is the status of the house defense, and of course on the local anatomy. We will discuss each things as the cases. We will discuss the cases. And once the bacteria reaches inside the mandible from the tooth, now it depends that how does it spreads or in which facial space it will go. And there are certain factors which determine this. Is the most important is which tooth is involved. Another factors are what is the curvature and the length of the root of the involved teeth, where exactly it is emerging. What is the thickness of the alveolar bone around the root or around the apical portion of the root, from where the infection is emerging. Then once the infection has perforated the maxilla or mandibular alveolar plate, then at the site of perforation, what are the surrounding muscular attachments are there. So these things determine which space or where exactly this infection will travel out of the bone, out of the maxilla or the mandible. Like for example, if you'll see the lateral incisor, upper lateral incisor, most of the time that upper lateral incisor root is palatally curved. So when there is a periapical infection in the upper lateral incisor, it usually represent as a palatal infection or palatal abscess. But then other incisors whose roots are labially inclined, so their periapical infection usually have a vestibular abscess or canine abscess in case of canines. So it depends on what is the uh, anatomy of the root of the tooth. Then another very important feature is what are the muscular attachment the bone is having. Like in the mandible, you can see that either your infection can come out above the myloid line, above the attachment of the buccinator, or it can come out below the attachment of the buccinator. Sometimes it can come out below the attachment of the masseter. Similarly, on the medial side, your infection may come out above the myloid muscle or below the myloid muscle or below the medial carigoid muscle. I'll explain each of these things and how this affects. Now you can see this. Now this bacteria has traveled out of the tooth into the mandible. And now for some reason, because of the poor host defense, now it is perforating the mandibular cortex. Now depending on the site of perforation of the mandibular cortex in relation to the myloid muscle, this will decide where exactly our infection will represent. If this perforation or the traveling of the infection is on the buccal side, if it is above the attachment of the buccimeter muscle, it will represent as a vestibular abscess. But suppose this perforation is below the attachment of the buccimeter muscle, this will lead to a buccal space infection. So a lot of things depends where exactly the perforation is happening, or rather you can say what is the length of the root, where exactly its apex is there in relation to the buccimeter muscle attachment. In this diagram, again, you can see the same thing in this molar. If the perforation is below the attachment of the buccimeter muscle, it will lead to vestibular abscess. If the perforation is above the attachment of the buccimeter muscle, it will lead to buccal space infection. So same tooth, same etiology, but the severity may differ. So this is once the infection reaches into the buccal space. So buccal space is lined medially by the buccimeter muscles and laterally by the skin and the subcutaneous tissue. So there is plenty of loose connective tissue is there in this space. So as soon as the infection reaches there and the organism multiplies, so there are higher chances that you will develop a huge swelling here, because infection can rapidly spread there. There is no resistance here. So this leads to buccal swelling. So this is how buccal space infection represents. So most of the time, patient will be having pain and there will be swelling on the cheek with the other signs and symptoms of the inflammations. So these are all example of buccal space infection. Similarly, if the infection perforates on the lingual side of the mandible, again it depends whether it is perforating above the myloid muscle or below the myloid muscle. If it goes above the myloid muscle, it will lead to a sublingual space infection. If it goes below the myloid muscle, it will go to submandibular and submental space infection. So again, it depends where is the attachment of the myloid muscle and what is the length of the root, where is the apex of the root in relation to the attachment of the myloid muscle. So if patient is lucky, it will lead to sublingual only. If the patient perforates below the myloid muscle, it will lead to submandibular or submental space. So now when we talk about submandibular space, we can see this is the boundaries of submandibular space below the lower border of the mandible and surrounded by the anterior posterior body of the digastric. And anteriorly, between the two anterior belly of digastric, this is the submental space. And now the important point is to see is, you can see that both of these spaces are in close proximity to the pharyngeal spaces. So this is your, you can say lateral pharyngeal or parapharyngeal spaces are there. So it is not, if the bacteria is very virulent or the patient is late to report, then these infections from one space can easily travel to another space. A submental space infection can travel to submandibular, and a submandibular space infection can travel to a parapharyngeal or retropharyngeal space also. So this is submental and this is submandibular space. So you can see again, this is how these cases represents. This is a classic example of submandibular and submental space involvement. You can see a submandibular region is swollen up. Again, another example of submandibular space infection. So these are easy to identify. In this picture, if you see this girl, the tongue is also raised. She is not able to close her mouth because it is a classic case of Ludwig's angina in which the bilateral submandibular, submental, and as well as sublingual spaces are also involved. So because of sublingual space edema, the tongue is raised. So this is known as Ludwig's angina. Otherwise, there are type of, these are just another type of submandibular and submental space infection. So now you can see again the same point I would like to emphasize, that these infections can spread from one space to another. Like you can see that this is a submandibular space infection. This submandibular space infection, as it grows, now it can escape above and below the digastric, and it can go inferiorly and laterally, inferiorly and medially towards the lateral and parapharyngeal spaces. And now you can see that once the lateral and parapharyngeal spaces will be occupied, they will displace the important vital structures. Or submandibular space infection can go upward and posteriorly towards the submasseteric or masticatory space involvement also. So most of the time you will see that when the masticatory space infection is there, this is related to a position of third molar. The position of third molar is very important. If the third molar in the patient is horizontal or mesoangularly inclined, so usually from that type of pericoronal or periapical infection, the infection usually first is spread towards the submandibular region, and then from the submandibular it can go to masseteric. There are higher chances that from this molar or from this pericoronal tissue, the infection will first go to masseteric spaces, and then from masseteric spaces they will come to submandibular space, and then from submandibular space they can travel to lateral pharyngeal spaces also. So you can see that from third molar, infection can travel backward towards the masseteric space. So this is the involvement of masseter, medial pterygoid, and temporal space and lateral pterygoid also. So this is collectively known as masseteric space infection. So this is a typical example in which the temporal space and buccal space both are involved, especially when the masseteric spaces are involved, when there is only masseter muscle is involved or medial pterygoid is involved, then there will be no outward swelling is there. You will not be able to identify the swelling or the space which is involved. The only characteristic feature in this is the pain and trismus. Patient is not able to open the mouth because the masseter and medial pterygoid are in spasm because of the infection around them. But as such, there will be no outer swelling until unless the infection spreads from masseteric space to either parapharyngeal or lateral pharyngeal space or submandibular space or upward towards the temporal space. When we travel down towards the neck, see these are the spaces in the neck bounded by superficial fascia and the various layers of the deep cervical fascia. If we go into detail, this is skin, and below the skin, as we have seen in the first dissection pictures, there is a layer of subcutaneous tissue which we call superficial fascia, and beyond the superficial fascia, you will see that this is platysma is there. So this is the layer which is usually involved in superficial fascia infection, or which is also known as necrotizing fasciitis. So necrotizing fasciitis usually involve the superficial fascia. So in these cases, the infection can either, usually the most common cause is either a skin injury, a piercing skin injury, or the submental space infection, from where the infection can travel in the superficial fascia, and it can travel down also. You can see up to the neck. And once this superficial fascia is involved and the patient treatment is delayed, usually the patient loses the superficial fascia, the skin, superficial fascia and platysma, and the muscles are exposed. So this is what happens in necrotizing fasciitis. So you can see in this patient, you can see the entire skin is inflamed. This is the early stage of cellulitis. And this is a picture from another patient in which you can see the entire skin, superficial fascia and platysma is lost because of necrotizing fasciitis. And you can see the underlying muscles are exposed. Even the muscles are started necrotizing. Then as we go further deep, beyond the superficial fascia, this is the parapharyngeal space around the pharynx and the trachea. These are the carotid spaces which is surrounding the carotid sheath, and these are retropharyngeal space behind the pharynx, and this is prevertebral space just behind the retropharyngeal space and ahead of the vertebra. So these are different spaces are there in the neck, which are again are filled with the loose connective tissue, but these spaces can be indirectly involved by dental infections. So first, infection may travel to submandibular spaces, sublingual spaces. Then from there, it can involve the lateral pharyngeal, parapharyngeal, or retropharyngeal spaces. So you will see that how this infection spreads. So the most critical point is usually it is because of the third molar infection, or the reason the posterior mandibular uh, dental region. So from where, what are the possibilities? Suppose there is a pericorneal infection or the periapical infection in the lower third molar. How once it breaches the mandibular cortex, or the infection breaches the alveolar cortex, where all it can spread. So you can see that it can lie superficially into the outer wall of the lateral pharynx, that is lateral to that is above the superior constrictor. So it can enter into the tonsillar space. So this is known as paratonsillar space infection. So patient will usually have a bulge into the lateral wall of the pharynx. Intraorally, you will see a bulge in the lateral wall of the pharynx, and patient will have a soft voice. You can classically you call it a hot potato voice, and patient will have a difficulty in deglutition and swallowing. So this is because of a superficial infection through a third molar region. Now, instead of going backward, depending on the tooth position, if the tooth is mesoangular or horizontal, this infection could have traveled labially also. So this, if this infection, you can see it has traveled in the vestibule only, along the external oblique ridge, and you must have seen that because of the some third molar, there are certain abscesses are there in the you can see them in the buccal vestibules along with the external oblique ridge, or it can travel outside the buccinator also, involving the buccal space or the submandibular space. This is superficial. Now it can travel deep into the masticatory space. Now you can see the infection has traveled between the mandible, lateral border of the mandible and the masseter muscle. So this can again lead to severe trismus and the pain to the patient, but as such there will be no swelling. Or it can travel medially between the medial pterygoid muscle and the medial surface of the ramus. Again, there will be no swelling, but a patient will have a trismus. This infection can further spread into the lateral pharyngeal spaces, which is adjacent to it. Now, patient will have not only trismus, but patient will have difficulty in swallowing. There will be a visible swelling into the inner, into the lateral portion of the pharynx. So you can see that the lateral portion of the pharynx is involved. Then gradually, after parapharyngeal space involvement, this can lead to involvement of the carotid sheath also, or carotid space also. The carotid space is popularly known as the Lincoln highway also. The highway, it is called as a Lincoln highway also because it directly it gives a pathway for the infection to directly go to the towards the mediastinum through the carotid sheath. So it is a dangerous environment, and other especially in the post-operative patients who has underwent neck dissections, whose carotid are exposed, whose carotids are fragile. In these cases, because of the secondary infection, it can lead to rupture of internal jugular vein or carotid artery and can lead to bleeding, severe bleeding. Then it can further spread from the lateral pharyngeal spaces. It can further spread into the retropharyngeal spaces. So again, it will same. The symptoms will be same. The patient will having a swelling into the posterior wall of the pharynx also, and patient will be having pain, trismus, and dysphagia. And sometimes, rarely, this infection can involve the prevertebral space also. The prevertebral space is between the vertebra and the alar fascia. If the prevertebral space involved, it is known as the danger area or the danger space. Why this is known as the danger space? Because this space is in continuation with the mediastinum. So any head and neck infection can travel down towards the mediastinum, and it can involve the pericardium and the lungs also. So this is you can see that from base of skull, this is traveling towards the mediastinum. So any infection in the prevertebral space can lead to involvement of mediastinum, pericardium, and pericardium. So this is a dangerous space. In this patient, you can see that the infection is traveling down towards the chest. So this is following the same path. Again, there are certain more things are there which can complicate your space infection patient. That is, one is your sublingual space infection. If it is not treated timely, it can spread backward and then once the edema is or the abscess is too much, it can press the epiglottis and it can lead to respiratory difficulties because the epiglottis is compressed. Or sometimes, as we have seen that when there is parapharyngeal or lateral pharyngeal wall or retropharyngeal space infections are there, they can again, when they become, there is a massive abscess collection is there, it can again lead to pharyngeal bulge or pharyngeal obstruction. So this also leads to dysphagia and pain in the deglutition, and especially this causes a problem when we try to intubate the patient. So when we place when we try to do a blind intubation, when we try to do intubation, because of the force of the intubation tube, these abscesses can rupture inside the pharynx only and can lead to an emergency situation. Another complication which can happen with space infection is the involvement of cavernous sinuses. As we all know that this is a dangerous space around the lips, and it represents something like this, in which you have proptosis, ophthalmoplegia, and opticular involvement. Then one more thing is we should know about is when the carotid space is involved, after the involvement of parapharyngeal spaces, there is a classic syndrome which is known as the Horner syndrome. What is Horner syndrome? The Horner syndrome is because of the involvement of the nerves in the carotid spaces. So when these nerves are paralyzed because of the space infection, that patient typically represents like this. And the patient is having ptosis, the patient is having meiosis, and patient is having anhidrosis. So this is known as Horner syndrome. So this gives you an idea without having any MRI that your patient is suffering from carotid space or parapharyngeal space infections. So these are the cardinal signs everybody is aware of. Whenever there is a space infection is there, the patient will usually have one of these signs. So now when you are able to identify this space infection, you have to determine the severity of infection so that you can act according to that. So if patient, apart from the other features, if patient is having a difficulty in swallowing, breathing or chewing, it is an emergency. You have to act immediately. Similarly, if patient is going into toxicity, there is a systemic involvement of high temperature and tachycardia, tachypnea is there. You have to admit him. You have to start IV antibiotic. You have to admit him. You should not treat him as an outdoor procedure. You should not rely on the blood pressure, because blood pressure is the last vital sign to fluctuate with the space infections. So if any patient is having a toxic appearance or a patient having systemic involvement, you should admit him and immediately start the IV antibiotic. Of course, this is everybody must be aware of it. They have to differentiate between cellulitis and abscess. So if it is a cellulitis stage, we know that we don't have to drain it. We can manage it with the control of the infection with the help of by removing the offending tooth and by giving a proper antibiotic. But if it is an abscess, then because it is a localized circumscribed incision, we have to drain it, because in the abscess there is no blood supply. The antibiotic cannot reach there. So you have to drain it so that the blood supply can improve in that area and the antibiotics can reach there. Most important point in managing space infection is always to evaluate host defense. There are patients who has uncontrolled diabetes. There are patients which are very common, alcoholic patients are there, malnourished patients are there. These patients have a very poor host defense. Similarly, post radiotherapy, chemotherapy patients who have renal or liver disorders are there. Their host defense is compromised. So even a small dental abscess can lead to catastrophic space infections. So you have to manage or improve the host defense in order to manage the space infection. So of course, we start antibiotic, we do everything possible, but surgical management is the key part when the abscess has already developed or when the abscess has involved the facial spaces. So first thing is you want to drain the abscess, and then you remove the other parts, that is the necrotic debris, because otherwise the body will keep trying to remove it, and there will be no, that you will always have, you will continuously have discharge from that site. But if you remove the necrotic part, the patient will heal early. Then finally, you remove the cause of infection and try to improve the host defense. If there are certain cases, Suppose there is a recurrence case, or suppose there is a resistant case is there, or there are other cases in which the host defense is very much compromised is there, or if it is a rapidly spreading space infection is there. So before INT, it is advisable that you do culture and sensitivity, so that you, instead of empirical antibiotic therapy, you can give a target oriented antibiotic therapy. So you have to do it before starting the antibiotic. So the best method to collect the culture is culture material is to have by doing by aspiration, because you can and do it externally. You prepare the site with the betadine and then puncture it and aspirate it. So by this way, uh, the sample is not contaminated by the other residential bacteria, and the anaerobic bacteria can also survive. They are not exposed to the oxygen. Taking a swab is another method, but there are higher chances that you can come contaminated with the commensal bacteria which is present there on the skin or the mucosa. And immediately you should send it, within minutes you should send it to the lab, so that they can be go for culture. Otherwise, if you delay it, you will lose the bacteria. The choice of antibiotic, we know that the amoxiclav or the combination of amoxicillin and clavulanic acid is the choice of antibiotic, along with the metronidazole. Then there are other antibiotics also, depending on the patient requirements. Our departments, we frequently use, if the patient is resistant to amoxicillin, then we frequently use either linezolid. If linezolid is also not working, then meropenem is another resort of the drug. Of course, antibiotics are not necessary when you have dry socket, when you have mild pericoronitis, or well-defined chronic well-localized abscess or vestibular swellings. In every case, don't start antibiotics blindly. So after starting the antibiotic, now when it's time to come to drain, there are certain sites where we give incision, and then we deepen the incision. When we cross the, first we give incision in the skin, then we go beneath the skin, there is superficial fascia there, then platysma will come. Once you incise the platysma, then most of the time you will enter into the spaces and you will be able to drain the space. But when you see these incisions are given in a way that you don't damage the any of the nerves, either facial nerve, branches of the facial nerve. So this is how we drain. We first give a skin incision, superficial skin incision, then we deepen it toward the superficial fascia. Then the platysma is exposed. Once the platysma is exposed, we enter our mosquito forces beyond the platysma, and the pus will drain through it. Once the pus is drained, then we place a corrugated rubber drain or any other rubber drain inside the uh, space, involved space, and we suture it, we stabilize it with the suture. Like when we talk about the submandibular space involvement, this is how we drain it. We incise the skin, we incise the superficial fascia, platysma, and then as soon as we incise the we put our mosquito forceps inside the submandibular space, and when you open it, it will start draining. Like you can see, this is the space of Ludwig's angina. The submandibular space as a sublingual space is involved. So given a skin incision, platysma is, now we are perforating the platysma with the mosquito forceps, and as soon as we have perforated the platysma, you can see the abscesses start draining. Once you have drained the current abscess load, then after that you will wash the space with the saline, with the hydrogen peroxide, or with the mixture of hydrogen peroxide and the betadine, and then you place the drain and give a pressure dressing. Sometimes if you don't have drain, you can use the rubber gloves also. Like I would like to show you a video in which is showing how to do the drain. Like this is you can see that we are giving the incision in the temporal region. Now this, when the superficial fascia has been incised, now we are entering into the space with the mosquito forceps. With slight force, you can enter into the space, and now when you open it, the abscess will start draining. You can see that. So these procedure can be done under local anesthesia, but you have to give a proper infiltration so the patient doesn't have pain. Usually we take it for granted that if patient is having space infection, the IND will be painful. But it's not like that. If you have patience and if you spend enough time, you can anesthetize the entire area. Rather, you should fill the space also with some amount of local anesthesia so the patient will not have any pain. You can see this patient's expression; he is not having any pain. Now, once the abscess is drained, we put a corrugated rubber drain with the help of artery or a needle holder into that space. This is important that the upper part of the rubber drain should enter into that space, not into the subcutaneous tissue. And then you check the patency of that drain, and then you suture it with the underlying skin. This is another video I'd like to show. You can see that we are doing the infiltration. So nice infiltration is very necessary so that patient has a painless IND. Now this is, you can see the amount of necrosis in this patient. As we give incision just over the skin, the abscess will start draining. It means the platysma, till platysma, everything was necrosed. Had we have not done this IND, within, I think probably within 1 or 2 days, there would have been a skin sinus. So again, now we will drain the abscess, and then we will irrigate the space with the hydrogen peroxide and betadine, and then you will put the corrugated rubber. So the same principle you have to follow. Similarly, in the buccal space infection, when the buccal space is involved, usually because the buccal space involves the cheek, it is not aesthetics to give extraoral incision. Most of the time, you can drain it through an intraoral incision. So you give an incision in the mucosa, and then you perforate the buccinator muscle, and you will directly enter into the buccal space. But sometimes the patient comes late, and when the skin is already necrosed, then you can drain the buccal space infection through the extraorally also. So now you can see that this is a intraoral drainage through the mucosa, perforating the buccinator muscle. But in this case, the skin is already necrosed. You can already see that there is a sinus is there. So it was drained extraorally. Sometimes both the buccinator and the submandibular spaces are involved. So from one submandibular space, submandibular incision, you can drain both the spaces. This is temporal space. You can see we give our incision parallel to the zygomatic arch so that we don't cut any of the nerve. So we just give an incision through the skin and the superficial temporal fascia, enter into the temporalis space and open the artery forceps, and the abscess will start draining. Can you see this bubbles? These bubbles are indicating of anaerobic infections. This is the CO2 which is forming inside, and when we drain it along with the abscess, the bubbles are coming. This is indicating that it was an anaerobic infection. So again, you can see that the drain is placed and it is washed with the betadine and iron peroxide. Same type of example, temporalis and submandibular space infection drainage. So you should realize that it is not necessary that only one space will be involved. Simultaneously, multiple spaces can be involved, and you might have to do incisional drainage at the multiple sites to properly relieve the patient. One important aspect of IND is when you want to drain the masticatory space. See, this is a very common mistake, especially in the earlier days of our training. The patient is having masticatory space involvement or medial pterygoid space involvement. Still, when we give incision in the submandibular region, we go inside and you'll see that there is no pus coming out. So this happens because the pus is localized beneath the muscles. So we have to perforate this muscle, or we have to go beyond this muscle to drain the pus. So the idea is you place your artery forceps up to the lower border of the mandible. You feel the lower border of the mandible, Then, depending on the masseter involvement or medial pterygoid involvement, you go either lateral on the lateral surface of the mandible or on the medial surface of the mandible, and then you enter into the masticatory spaces and the pus will start draining. So this is typical. If you don't perforate the muscle, the pus will not drain. So this is where exactly we go for the masticator muscle drainage, and this is where we go medial to the lateral, medial to the ramus to drain the medial pterygoid space drainage. Another typical part is when the lateral pharyngeal space or parapharyngeal spaces are involved. It can be drained easily through a intraoral incision. The intraoral incision is given in the retromandibular region, and then depending on the involvement, if it is superficial to the superior constrictor, that is the tonsillary space is there, you go superficial to superior constrictor. If it is typical parapharyngeal space is there, then you perforate it the superior constrictor also, and you go medial to that. But if it is a deep infection involving the retropharyngeal space also, then it is always better to give extraoral incision at the anterior border of the sternocleidomastoid. You go between the sternocleidomastoid and the posterior belly of the digastric, deep towards the mandible, and you will be able to drain the retropharyngeal spaces. So now you will see the example of how severe these cases were there, and we were lucky to treat these cases successfully after IND. These are different cases. This is another type of case which you will frequently encounter, that is the mid-palatal abscess. This can happen by involvement of any of the tooth which is draining palatally. The problem with these is once you give an incision in these abscess, the abscess will come out. But if you leave it like this, this incision will heal, and again the next day this swelling will recur because of the edema fluid collection. So in these type, because of the dependent drainage, because of the gravity, so in these type of abscess, you have to make a bite plate also, which can cover the palate and which can apply the pressure over this abscess, so that this mucosa can adhere again to the palatal surface. So if you give a bite plate, you will see these type of results within 1 or 2 days after the IND. Another important aspect of space infection is the management of trismus. See, you might drain the abscess, but still there is, because of the localized irritation, the muscles are in spasm. So patient had to do active physiotherapy to keep his mouth open. Then there are certain examples that what happens if we delay the treatment. You can see these are the patients in which the entire skin has lost up to the mandible because they are late in reporting or they are late in getting the treatment. So the entire thing is lost, and now you have to, once the infection is controlled, you have to reconstruct it with either one of the flap. You should also differentiate the space infection with draining osteomyelitis, bony infections. They are not a space infection, they are just draining sinuses from the bone. So you have to differentiate them, because in these cases you have to treat the bone, not the soft tissue. Another very important variant of space infection is necrotizing fasciitis. Now you see this gentleman, he was not that severe. He looks almost stable when he represented like a Ludwig's angina, bilateral submandibular space infection, and as such, apparently there was no necrosis. But when we give the incision to do IND, you see the beneath everything is necrosed, beneath the skin. So it is a rapidly spreading infection into the superficial fascia. It is necrotizing everything beneath the skin, and gradually the skin is also being necrotized. So as we have already discussed, the superficial fascia is involved and it rapidly spreads. So it is not confined. There is no abscess formation. So if you don't tackle it at timely, it can become fatal also. So it has got a deceptively benign appearance because apparently the skin is normal, but it can be mistaken as cellulitis, but the underlying necrosis is severe. And it is very common in old diabetic patients. So the treatment again is you have to remove the diseased fascia, you have to remove the necrosed bone, and frequent dressing and irrigation. So now you can see that when you give the incision, the underlying fascia is necrosed. You do blunt dissection. Blunt dissection is with the blunt dissection, you usually easily separate the necrosed fascia from the underlying deep fascia or the muscle. You can see that even in this case, the deep fascia was also necrosed. And the characteristic feature is there will be no pus formation, because for pus formation, it has to be a localized infection. So there is no pus. The fluid which is coming out is not pus. It is a edematous fluid, watery, thin, grayish brown, foul-smelling pus. It is popularly known as dishwater exudate, which is spreads in the multiple planes. And this is how, suppose if it is a long-standing case, the muscle will also get involved. Like in this case, you can see the digastric and myloid is necrosed. Now you have to do very hard work in rehabilitating these patients. Like you can see the disease condition of this skin. This is the necrosed muscle. There are deep pockets. And when you do keep on doing dressing, it will gradually improve. You'll see, can you see these cutaneous blood vessels? These vessels can, usually in the necrotizing fasciitis, these vessels get thrombosed and the skin get necrosed. And there are deep pockets are there in which the anaerobic infection prevails. So when you do keep on doing irrigation with the hydrogen peroxide and betadine, some people use Usol also. Gradually, it improves. And now when you see, can you see the improved condition? The pockets, first the pockets will heal. There will be no pockets. And the fresh granulation tissue, healthy granulation tissue will appear there. This was when unhealthy thing were there. Now you can see the healthy granulation tissue. And you can see these pockets are healed. The margins are attached. And gradually these ulcers on the skins also start healing. And then if you want, at this stage, either you can put a skin graft or a pedicle flap, or you can leave it for a secondary healing also. So mostly secondary healing is sufficient enough to manage these type of cases. You can see this case. So necrotizing fasciitis is another case in which leads a sincere supervision in these type of cases. Another type of example, you can see same type of case in which the submandibular and submental space is involved. But when we give incision, you can see the dish watery fluid is coming out. And you see, this is once we remove the necrotic part, again you can see the entire muscles are involved. This is after repeated dressing, and you'll see that if you do the repeated dressing judiciously, religiously, there will be improvement in the patient. Now you can see the patient is gradually improving, and the lesion is being secondly healed. This is another form of necrotizing fasciitis. You can see the facial skin and the mass layer is affected. This patient was, again, he was having myeloid dysplasia. So because of the immunocompromised condition, probably he developed this infection. We were not able to manage this patient with the amoxicillin. So we started with linezolid and the 3 or 4 times daily dressings with the hydrogen peroxide and Lysol. So finally he recovers. So this is again a typical picture of facial space infection, necrotizing facial space infection in children, especially the malnourished children in our type of underdeveloped countries. You can see that because of a trauma, or because of the cheek bite, because of the lip bite, or because of a periacal infection around the incisors, the canine patient can develop these type of buccal infection, which lead to necrosis of the skin. Now this is, you can see that after debridement. So this is typically known as noma. So this is common in underdeveloped countries, and this is very, very devastating for the patient. And reconstruction is very difficult for these patients. So this is a socio-economic problem. We have to deal these patients very carefully. Now, before winding up this lecture, just a few current cases of post-COVID necrosis of the maxilla. So you can see nowadays there are many cases representing after incidence of corona, after incidence of COVID. So these patients usually represent with pain in maxilla, or pain in maxillary teeth, where the teeth are mobile, and there will be draining sinuses in the vestibule, especially involving the attached gingiva. So can you see these are multiple sinuses are there involving the attached gingiva? This indicates that the underlying bone is necrosed and body is trying throughout the necrotic part. So that is why there are sinuses are there. These all teeth were mobile. You can see there is swelling in the palatal aspect of gingiva also. This indicates that the necrosis is not only involving the buccal plate but also the palatal part also. So by the time patient reaches to us, it is too late. We cannot manage it with amphotericin or other osaconazole or other antifungal. Now the only thing which is remaining is to debride it, to drain it. So you have to remove all these teeth, all the necrotic part, and do the open dressing, so that in case any remaining necrose part is there, you can remove it also. You can see the most of the time the OPG looks normal, the IOP looks normal, but on the later stage, you can see the diffuse bone loss in the CBCT, which gives you an idea that it is getting necrosed. But basically, we are not dependent on the radiological findings. The clinical findings are sufficient enough to decide that this is necrosed and you have to remove. If you don't remove this necrosed part, this usually spreads to adjacent teeth. So this is after removal of the necrosed part of the maxilla, and then we prefer to do open dressing with the iodoform. This is another patient. You can see the palatal mucosa, palatal bone, everything is necrosed. Everything was mobile, so we have to remove all these things. Can you see the color of the bone? This is the necrosed bone. There is no bleeding. So you have to remove all this and do the open dressing. Gradually it heals, then you can rehabilitate with either obturation. We have not done yet any zygomatic implant in these cases. We are still waiting for another case. Same type of case. You can see the necrosed bone. You have to remove all these things. Another you can see a severe case in which the bilateral maxilla is involved. This was done in our department by Dr. Sunil Jakar. So again, we have to remove the entire of the maxilla, like a leaf foot one osteotomy. So this is all. This is a severe problem post-COVID. Then before winding up, I would like to emphasize that every swelling on the face is not a space infection. Like this is again very common type of swelling, which many times patient reports that sudden swelling is there, which is painless and mostly unilateral. So this could be allergic angioneuritic edema. So you have to take a proper history to differentiate these cases. Patient will give you a history of frequent occurrence of these type of cases, and it will be painless, and gradually they subside with the anti-allergic things. So this is usually because patient is allergic to something, angioneuritic edema is there. Then this is, you can see that this swelling is again, it is not a space infection. This is a underlying squamous cell carcinoma which is involving the skin. Then again, this is a swelling post restorative procedure. So post restorative procedure, this is a sudden swelling which has developed. Again, this is painless, but when you palpate it, the crepitaces are there. So this is nothing else but a surgical emphysema is there. So this may lead to a space infection, but right now it is not a space infection. This is a surgical emphysema. This is another swelling which looks like patient. This girl comes as a sudden swelling because and pain in this region. So it looks like a buccal space infection, but it was not a buccal space infection. It was a secondary infection in a slow flow venous malformation in the cheek. Similarly, this boy, he also represented as a sudden painful swelling into the cheek. Again, looks like a buccal space infection, but again, this was a secondary infection, is a high flow artery venous malformation in the mandible. So you have to be very careful before deciding or before jumping to IND or before thinking that this is a space infection. Thank you very much. So before winding up, I would like to say that this is a very popular saying that never let the sun set over an undrained abscess. So if it is a abscess is there, you should immediately drain it. Don't let it spread and let the patient be vulnerable to any life-threatening condition. Thank you very much. If any questions are there, we can discuss it right now also. Or you have my email ID and phone number. Later on also you can discuss the things.
Yes, sir. So there is a one question is there. Can explain a difference between a Hilton method of
Yes.
drainage and Vazroni method of drainage? Galaxy.
I am aware of the Hilton's method, in which we give a incision, we enter into the space, and then we put the mosquito forceps, and then we spread it along the direction of the vital structures, and then later on we place the drain, whatever drain is there. The second method, the Varanasi method, probably either I have forgotten or I am not aware of it. If you want, I can read it and let you know.
Any other questions? Yes. I think. Yes. No questions, sir. Yeah. Rushit?
Okay.
Yes, sir.
Yeah.
I don't think there are any more questions because the presentation was absolutely wonderful. Especially the anatomy slides were so self-explanatory, sir. Thank you so much for a wonderful presentation.
Most welcome. Thank you very much, everybody.
Sir.
Shall I leave the meeting?
Sir, thank you very much, sir. Sankalp, sir.
I should thank
especially,
you for keeping patience.
I would
and,
like to thank all the participants and Sankalp, sir. It was an excellent, I can say that excellent presentation, sir. We have also
Thank
like excellent use of audio, visual, and animations and all. And it is very nice. Thank you, sir. Thank you for giving your valuable time. Thank you very much.
Thank you. Thank you.
Thank you.
Thank you, everybody.